Thank you. Thanks for the introduction. Thanks for coming and for giving me the opportunity to tell you about HealthPals. So, it's ironic that we're sitting here in the Future Hub and my question is going to take us all into the past. How do you disseminate and empower knowledge? What you're seeing here is a drawing from the 1400s of a printing press, which we think is one of the earliest technologies that disseminated and empowered knowledge. And I'll come back to this theme at the end of the talk. The RAND study over 10 years ago taught us that about 50% of all medical decisions we make as providers are either wrong or suboptimal based on the evidence. This is leading to poorer outcomes, higher mortality, and higher cost. And HealthPals, we think that the reason for this is that clinical decision-making is failing at the point of care. And it's not hard to see why. When a provider sees a patient, they're focused on the chief complaint. And they may do a great job from an evidence-based standpoint with that chief complaint, but due to time constraints, due to over 1 million medical journal articles published each year, it's impossible to keep up with the standard of care for all of the other chronic disease states that will impact that patient long term. As a result, you miss that opportunity. We believe that precision population prevention is the best way to fix these errors, that using something that is automated, personalized, and evidence-based, like a HealthPals solution, will drive decisions towards better outcomes. I'm not going to be able to tell you more about the huge problem. All of you know how big this problem is, but there's also a massive opportunity. The CDC has published these numbers, but the most important one is up at the top, that 80% of heart attacks and strokes they believe are preventable with early detection and treatment of risk factors. They've even given us a playbook to actually treat this using electronic health records to identify patients who are at risk and focus on the guidelines, basically the ABCs, the data that we know will work for these conditions. And lastly, to involve all the care continuum to operate at the top of their license. Clint, our clinical intelligence engine, addresses all three of these domains by leveraging digital EHR data and other patient data, applying it to codified guidelines, and allowing this to be disseminated to all the providers in the care continuum. So how do we do this? And I'll show you that in our demo right now. So what you see here is an individual patient record. It's the fundamental unit of our population view. The EHR data has been ingested into the Clint platform with all of the relevant information and attributes. And you see a donut with the 15% risk of heart attack or stroke in the next 10 years by QRIS2, and you can use any risk score you wish. You can also see the breakdown of the individual risk factors contributing to that total risk, those that are not changeable, like ethnicity and family history, and those that are. And you can see that impacting her smoking and treating her with a statin will actually would have made her a low-risk patient, but treating her blood pressure would not have. And actually, this helps you prioritize the most impactful interventions for your patients. And you can see every intervention by a guideline or an internal quality metric applicable to that patient at that moment. But this isn't just happening at the point of care, it's happening throughout the continuum. And as a result, and before I leave, to show that you can actually track quality metrics, and we've also added ethnicity lenses and social determinants of health, which are so important to outcomes. That's the fundamental building block of our population view, which actually compiles individual records across the entire clinic to show your distribution of risk, and as well as every guideline-driven recommendation for your population. Those that have been completed on medication, lifestyle, etc., and those that have not, and a prediction layer to show the impact of executing all of those recommendations on your overall risk. We've also extended this to cost, where we can actually model the impact of all your medication changes, were they to be applied, the actual risk reduction and cost savings for your health system. And we use heat maps in order to visualize this more effectively in terms of your opportunity as a health system. So, I'm going to go back. So basically, does our platform actually work? And so, next slide. We are currently engaged in 2 active clinical trials, and our early clinical results show in the highest risk patients that are refractory and preventive cardiology clinics that we can reduce using Clint overall cardiovascular risk by 1/3, involving both cholesterol, BMI, and also hypertension control. And by using responsive risk stratification across your population, we can eliminate follow-up visits for low-risk patients and increase new patient visit capacity, therefore increasing revenue and profit for clinic systems. Our differentiator is our medical science knowledge and expertise. We have all of the guidelines relevant for cardiometabolic disease, which is kind of our wheelhouse. However, we've spread significantly recently to include social determinants of health, ethnicity, and other adjacent domains, but also patient data to optimize treatments. At the end of this year, we'll have 250 million patient life years of data to run and train our machine learning algorithms with our IP geared towards optimizing individual patient treatment plans based on who you are and other people like you. So we believe we are creating the digital printing press for applied medical knowledge. Gutenberg didn't invent reading or writing, but a technology that enabled literature to become more accessible, affordable, and maximally impactful. HealthPals is making medical science more impactful by transforming data into accessible, evidence-based clinical action for the masses. We have an upcoming public release in the next few months, so please stay tuned for that. And every technology, even the printing press, comes at some price. So we are a seed stage company, raising a new round now with deployments in the following types of customers, including government health systems and social impact bonds, with a diverse team. So please come talk to us afterwards if you're interested, and thank you very much.
Okay, thank you very much. We'll take some questions from our judges.
I'll start off. Very good. I like your analytics strategy. I think it's more than what I've seen in many other places. The key question, I think what was missing was, if you have analytics, how do you change from precision to actually prescription? How did you engage with the patients after that to lead to the reduction of the numbers you showed? So I think that part is missing.
Yeah, so great question. Basically, I believe that data science on its own, if it shows you an insight, it's hard for a physician to make a decision based off just the ML insight that is derived. You need to have some core basis, whether it's clinical trial data or evidence-based decision-making. So we're optimizing through the guidelines with the ML platforms that we have. And eventually, I think ML will probably do more in that regard. However, the implementation is the other part of your question, which is how do you get patients to engage? We actually started building this product with a patient app, and our first initial results included a patient app with engagement through the care team, through a virtual health coach, and through virtual care team communication. But the key thing was that each patient was able to see everything that we were able to see, their overall risk, the impact of those interventions on their risk. And the feedback from patients was that that was really powerful for them to understand why they were being told to do something and how it was going to impact them long term.
Dipti?
Two questions. One is, just to follow up on that, I had a different question, but do you have to educate the patients to interpret that data, and how much time is being spent for that?
Right.
Because now you're adding work time for me. This is supposed to make me have less work time.
So all of the education is on there. If they have an app, the HealthPals app, for instance, all the education is already built into the app. So if we've given them a recommendation, we have not only content in the app itself for education, but we also link to partners such as the American Heart Association, their Simple 7, and that kind of programmatic influence.
My second question was, how easy is this to integrate into what's the workflow?
Yep.
How easy is it to pull it? I love the data, but how hard is it going to be for me to bring this into my daily workflow? So
2 answers to that question. One is we do integrate with EHRs. We use Redox, which is a great tool to do that. However, most health systems have their own user interfaces. We recognize that. We have a web API as a service. So basically, you can send us data, and we send you back insights and put it into whatever form you want into your EHR. But we also have our own interface, as you saw today, and we can integrate with those EHRs.
Malik?
Raj, who's the actual end user? Is it the physician or the population health team or the quality office? And what's the actual conversion rate between an insight to actual action?
Yep. So the actual user we found to be practice managers, quality officers, administrators at a population level looking at risk segmentation and resource allocation for their institutions. But we've also found a tremendous value of populating profiles at the point of care. And while we've started with population reports, those institutions can easily push that down to the point of care with our solution. In terms of conversion rate, that's what we're studying in our clinical trials right now. So we have one ongoing that's finishing enrollment now, and one hopefully, if the NIH is favorable, we have an STTR in getting scored in about a week to start another one in July. So.
And Tom?
And so just to follow up on that, in your validation plan, tell me the outcomes that you've specified in those clinical trials.
So right now, You saw some of them here, which is absolute risk reduction, biomarker reduction. However, decision making is actually an interesting before and after type of study, where basically we choose a population of physicians, we track in the background the Clint insights and what they actually do, blinded to what Clint would have told them, and then we do another similar number of patients after showing them the Clint insights and see how they improve their decision making over time. And then there's some modifications of that for some more interesting analysis.
And decision-making improvement is measured how?
So every opportunity to make a guideline-driven intervention is considered basically a unit of measurement for those physicians and their compliance with the guidelines as a percentage of those opportunities.
Wonderful. Thank you very much.